Good afternoon, everyone. Thank you for coming in on this gorgeous afternoon. I was thinking as I walked over here, but welcome. My name is Marianne Hunt. I'm the Assistant Director for Lifelong Learning and Travel. In our department, we strive to continually find ways to engage our alumni with our faculty and provide intellectually stimulating programs here at reunions. We also come to a lot of the cities where many of you have Dartmouth clubs and deliver a program we call Dartmouth on Location. And we also administer the Alumni Travel Program. So if you received any of those glossy brochures with some of our great professors leading the trips, that is our office. And I'm pleased to say that Lisa started working with us last year. She went to South Africa, and she's going to Botswana this fall. I'd like to just take a quick moment to ask you to silence your cell phones, please, or set them to vibrate. And then I also just want to put in a plug for going online and filling out the survey that you'll receive when reunions are over. We really want to provide you with the programming that you want, so we'd like to get feedback on how we're doing and get ideas for the next time you're in town for reunions. And at this point, I'm just going to have to apologize because Lisa is so accomplished and she has so many titles, and I'm going to have to read this. I was actually thinking about it the other day. I said, why did I volunteer for this one? It's such a mouthful, but I'm pleased to be here. I'm pleased to be here to hear about the important work that she's doing. And I'm happy to be introducing Dr. Lisa Adams, who's the Associate Dean for Global Health and an Associate Professor of Medicine in the section of Infectious Disease and International Health at Dartmouth's Geisel School of Medicine. She oversees Dartmouth College's Global Health Initiative at the Sloan Dickey Center for International Understanding and is the director of Geisel's Center for Health Equity. In all her roles, she develops and oversees cross-cutting global programs involving faculty and students. She has worked in domestic and international TB control for over 20 years and has worked in over a dozen countries to provide technical assistance to national TB programs. Here at Dartmouth, she teaches global health medicine to medical and college students. She has been a co-investigator on several clinical and operations research trials on TB and HIV through the Dar Dar Programs, which is a collaboration between Dartmouth and the Muhimbili University in Dar es Salaam, Tanzania. In 2012, she spent 6 months in Rwanda as Geisel's lead to launch a major medical educational initiative, the Rwandan Human Resources for Health Program. She is currently engaged with local partners in Swaziland to improve the delivery of TB care services to children and persons living with HIV. So please help me welcome Lisa Adams.
Thank you, Marianne, and thank you to all of you for choosing to spend what is a gorgeous Friday afternoon in Hanover inside this auditorium. I hope you'll find it is worthwhile. It's a small group, so let's keep it intimate. Feel free to stop me at any point if you have questions, want to hear something more. Let's keep this informal. So I already asked and heard that there's one physician in the group. Any others? So a few. What's your specialties? Pediatrics. And in the back? Psychiatry. Any others that I missed? Yes. Anesthesia. Great. And pediatrics. Sorry? Ortho. And ortho. Okay. Terrific. It's great to have fellow medical professionals in the audience. And again, happy to hear input from people as we're talking about our programs. And at the end, too, happy to engage in conversations if any of you are interested in learning more or finding ways for alumni to get engaged in our work. So I'm going to be talking about what we consider to be Dartmouth's impact in our two East African programs in Rwanda and Tanzania, where we focus on developing human capital for sustainable health. And I begin just with a picture here of Lingua, who is a Dartmouth College class of 2008, and she spent a year on a Lombard Fellowship working at our Pediatric HIV Care and Treatment Center in Dar es Salaam, Tanzania. Now, this is before she ended up going to medical school during her gap year. So she focused her time on providing those services to really make the clinic a family-centered, child-friendly site of care for the kids. So she did things like making sure that there was a well-stocked and child-friendly playroom for the youngest kids. She also helped develop a Saturday afternoon program focused on youth empowerment for some of the older kids. I think these programs are very important. I think it's a universal sentiment that young kids don't like going to the doctor's office. Many of them are terrified. So to be able to create this sort of welcoming environment, I think, was really important. And about the Saturday afternoon group focused on youth empowerment for the older kids, what was fascinating there is that we found that although the program was slated to be for an hour or two for the kids to get together and do different kind of educational games and have some educational conversation around topics that they were interested in, what we found is that the kids actually wanted to stay for 3 or 4 hours. They wanted to spend their whole Saturday there if they could, because this was it for them. This was their opportunity for enrichment, for stimulation outside of their classrooms. These were not kids who were being carted off to violin lessons or after-school programs or lacrosse games. This was it for them. This was their only extracurricular activity. And so again, we felt that these programs, while they might not be on the list of what a health manager or clinic manager, health planning folks might consider to be important, anybody who's a parent, a grandparent, or who spent time around young kids know that these are the programs that make all the difference in the world to kids coming to get care. So I wanted to start out by mentioning that our programs, the 2 programs I'm going to talk about today, are really under the umbrella of the Medical School Center for Health Equity. The center is a newly established center, established in 2013, and established in response to overwhelming student demand to provide a single home for programs focused on care of underserved populations in both global and domestic environments. The idea being that we really wanted to unite programs and not separate out programs focused on global versus domestic locations. And it turns out this was a really smart and unique move on our part. You may know that many schools, universities, medical schools across the country now have centers, initiatives, institutes of global health, but very few have such centers focused on health equity. We thought it was really important to not pit our domestic versus our global health programs, to recognize that there are more similarities than there are differences to providing care in these 2 different environments. And when you think about it, that distinction between global and domestic is really artificial. As one of my colleagues said to me recently, our global is always somebody else's local. So again, really trying to unite the global and local and environments and really tear down what we consider to be that artificial distinction. The other piece is that with the popularity of global health programs today, we have to acknowledge that we're experiencing a little bit of a global health bubble. And when the bubble bursts, as all bubbles do, we firmly believe that what we will be left with at the end of the day is what is the underlying core issue, the core value, which is a desire to promote health equity. So we feel by focusing on health equity now at Dartmouth, we're able to sort of leapfrog forward, and at the end of the day, we'll be seen as a leader in this space. So quite simply, our vision for the center is a world with health equity for all. And we intend to do this by engaging students and faculty in fostering durable international partnerships that will promote health equity in both global and local settings. And where are we doing this? We have 5 signature international sites that are listed here. As I said, I'm going to be talking about the 2 programs in Rwanda and Tanzania, but we also focus on domestic sites that are meaningful to Dartmouth. So that includes work with Native American communities across the country, and also working with communities locally in the Upper Valley, communities in need that are not very far from campus. So how do we do this work? Some of the ways in which we think we distinguish ourselves are by focusing on what I call the 4 I's. The first is working at that intersection of global and local health, as I've already talked about. The second is building on our already solid institutional partnerships. And we do this so that we can have a broad base of support for our work. The third is the concept of inclusion, or we might describe it as reciprocity, meaning that if we send one of our students there in this case being Muhimbili National Hospital in Tanzania, that we need to receive their students here. And these are two Muhimbili students coming to work at Dartmouth Hitchcock Medical Center. This is sadly not a universal concept in most international or domestic programs, but we feel it's very critical, and we know it has meant a lot to our partners to have this reciprocal nature, bidirectional nature to our work. And lastly, we take advantage of our small size and work in an interdisciplinary fashion. So what does that mean? Well, this is what working in an interdisciplinary team looks like. So this was a workshop that we had focused on discussing the challenges of addressing tuberculosis in the mining sector in South Africa. And around the table we had first Merritt Patridge, who's a recent Tuck alum, so bringing sort of the business and management expertise. Myself with the medical background, Jocelyn Paulson, who is a now Dartmouth alum as of a week ago, recent graduate who is studying environmental studies at Dartmouth. Two medical anthropologists, Sienna Craig and Elizabeth Carpenter-Song, who bring their expertise and understanding of how to approach health problems, populations, cultures, individuals from an anthropological viewpoint. Bob Drake, who's a psychiatrist focused on behavior change. And then the gentleman with his back to us is Will Boyce, who's a second-year medical student. You can't see on the screen, sort of situated where I'm standing, was a video conference panel with our South African partners representing similar disciplines. So the idea being that these are the kinds of disciplines, this is whom you need to have at the table if you're going to be working in an interdisciplinary fashion. So I am often heard saying, today's challenges in health equity are complex and multifactorial. Therefore, our solutions must be collaborative and interdisciplinary. And I think the best way to describe that is to say, if we look at this picture of this woman living in a low-income rural setting, and I were to ask you, what might we need to do to work with her and her community to improve her health? I think it becomes obvious pretty quickly that it's not just about plonking down health services or a health outpost or health center there, that it's going to require a whole host of disciplines. In order to improve health quite broadly, it's going to involve engineers and teachers. It might involve economists, medical sociologists, or anthropologists, as I've talked about, that the challenges to health here are so complex that it's not just about providing medical care or medical services. I've listed here what our main activities are. We focus on supporting education and training activities, conducting clinical and operational research, and of course practice, or what is called service. So this slide just is a kind of quick summary of our different educational activities in global health. And many of our educational activities actually begin right here on campus. So I teach, and have been for the last 9 years, a course in global health called Global Health and Society. It's in the geography department, so I, as a physician with my main appointments at the medical school, have an adjunct appointment in the geography department. There's many other global health classes now that are taught across different disciplines, and then we also have electives available for medical students. Many of these classes focus on the social determinants of health, those social and environmental factors that affect an individual's or population's health. And then we also provide training in ethics, professionalism, and cross-cultural humility for our students before they actually engage in any global health or cross-cultural work domestically, because it's so important for them to be well prepared before they start working with partners in these communities. Through the Dickey Center, there's a global health certificate that's offered to undergraduates, and we're in the process of developing a health equity track at the medical school for medical students. So again, quite a lot happens right here in Hanover. But of course, And the key elements is our international opportunities, those experiential learning internships, which maybe some of you participated in when you were at Dartmouth or at your own colleges if you're here with a Dartmouth alum. And we work in partnership with the Dickey Center for these opportunities as well. And of course, they're not solely about providing medical care, working in medical clinics. These experiences are around health policy, around conducting clinical research or sociological or anthropological research, and about community and health education and development. So they really span quite broadly across a number of disciplines. And then for our more senior medical students, we do have clinical care electives based in the clinics and hospitals and some of the sites where we work. And here we have one of our medical students, Oriel, working at our pediatric clinic in Tanzania, and Stephanie here working in a pediatric and maternal child health clinic in Port-au-Prince, Haiti. So now I'd actually like to ask you to join me in talking about my experience in Rwanda. I would like to say that this was one of the most personal and professionally rewarding experiences that I've ever had. So how did we land in Rwanda? So in 2010, I believe it was, then President Jim Yong Kim got a phone call from the head of the Clinton Foundation telling him about this new program to help rebuild the medical education system in Rwanda. And would Dartmouth like to consider being a partner in this? They were going to be contacting a number of medical schools, and I think Dartmouth or universities, and Dartmouth was the first phone call that was made. So I think that was an easy yes, that we'd like to learn more, we'd like to be involved in this, this very exciting opportunity. So if you fast forward 2 years through all the planning and preparation that was done for this program, in 2012, I packed up my family, my 2 kids and my husband, and we went and were actually the first physician to arrive under this program called the Rwandan Human Resources for Health Program, a very exciting program. It's a very bold and ambitious 7-year program, as I said, focused on rebuilding the medical education system in Rwanda. And it involves a number of schools now. There are about 8 medical schools involved in the consortium. We're amongst distinguished peers like Harvard, Yale, Duke, so we're in quite good company. And it's one of the most comprehensive programs, surely the most comprehensive program I have been involved in my 25 years of global health work, because it involves medicine, it involves nursing, it involves dental schools, oral health, it involves health management. So again, this is quite unusual. And within medicine, it involves 5 different specialties. I like to start out talking about Rwanda by showing this picture for 3 reasons. The first is that this is the scene that I passed every day walking from my house to where I met my carpool to get to the hospital every day, so it's a very familiar scene. Brings back some good memories. But also, I feel like this picture is sort of evocative of the social and economic transition that Rwanda is undergoing right now. If you sort of think of it in the sort of immediate foreground, we have the image of Rwanda's agrarian, subsistence level farming history. And then in the not too distant horizon there, we see the skyline of the capital city, Kigali. And that's sort of evocative how in the not too distant future, Rwanda has important aspirations to become an economic powerhouse in the region. It's got one of the fastest growing economies in the region. It's one of the least corrupt governments. And it also desires to be the IT hub for the region. And then thirdly is this picture also reminds all of us that Rwanda is really being built on the backs of women. That was certainly true in the immediate years after the genocide, and it's very much true today as well. Rwanda is one of the few countries with more than 50% of its parliamentarians being women. So just a few quick facts on Rwanda, and then I'll get back to more stories about it. But I think it is helpful to know that in the years around the genocide, Rwanda had the lowest life expectancy in the world. It was 27 years at that time. Hard to imagine. Great progress has been made, and now, today, life expectancy approaches that of her neighbors. Rwanda is also one of the poorest countries in the world, ranking number 203 out of about 227 countries in terms of GDP per capita. Rwanda has been hard hit by both the HIV and TB epidemics. Here's the adult prevalence rate, so about 3% most recently of the population is infected, not as high as some of her neighbors, certainly. And in Rwanda, there's also about 9,000 TB cases every year. Again, not as high as some of her neighbors, but still quite significant burden for both of those diseases. But these two bullets here about those, the percent on treatment and the percent successfully treated for TB are the two really astounding factors. Rwanda's been able to kind of be a phoenix rising out of the ashes, and through an extensive community health network has been able to achieve this kind of success. 91% of those who need treatment for HIV are receiving it. 90% chance of being cured of TB if you happen to contract it in Rwanda. This, to me, is what health equity looks like. This is about access to affordable, quality care, achieving these kinds of outcomes. So that, I think, is some of the ways in which Rwanda is helping lead the way in terms of what health equity could and should involve. And then this graph here just shows what we would expect, that as you have the number of individuals in the blue bars here, number of individuals, more and more individuals every year having access and being started on treatment, you see the red line here, deaths decrease dramatically. That, again, is a measurement of health equity. Nonetheless, Rwanda is also a country where there is a significant healthcare worker shortage. If you look at some of the numbers to help give some context for this, think of it this way. So Rwanda has about 1 physician per 20,000 individuals. The World Health Organization recognized having 1 per 1,000. And here in New Hampshire, we're at about 1 per 300. So kind of gives you a sense of the starkness of the severity. This is a pediatric ward in one of the hospitals that's not in the capital city, Kigali, but about 2 hours away in Butare, where the medical school is. It was recently renovated, but still full with patients, but not with physicians, unfortunately. Just another image, too, to help show how Rwanda is also experiencing a shortage of faculty at the medical school. So this picture kind of does it for me, because when I think about this large microscope lab with all the students trying to do their work, what's missing here is the circulating faculty, right? As you would see in a microscope lab here at Dartmouth or at any other medical school, or even undergraduate lab at the US. So that's what's missing here, is the faculty. So this is the entrance to the main teaching hospital in Kigali, and this is where I was placed for 6 months. And just to give you a visual of the outside of the hospital setting, the hospital is comprised of several of these small single-story stone buildings, each one housing a different ward. And you can see some of the wards listed here, and even with the different language, I think you can figure out what many of them are. So this is how I spent most of my time. This is inside the male inpatient ward, and what I was doing here was mostly one-on-one teaching during rounds at the bedside, teaching medical student here, Felix, working with the resident here, Theonest, and really trying to do that one-on-one teaching in context, which we think is most beneficial, most useful in all contexts. We also did do some classroom teaching, and this is a case presentation of medical students presenting a complicated, difficult case to the faculty, and we're having a discussion about it. And what, of course, I think is most remarkable about this picture is just how eager the students were for their educational opportunities. So even though that back row is standing and the row in front of them are kind of crowded out on the benches, nobody complained. Nobody complained about having to stand for an hour, because they were so pleased to have this opportunity for education. And then this is the inpatient ward, another picture of it where I spent most of my time, pictured here with Dr. Yuki Ayagi, who was an infectious disease fellow from Dartmouth who came over to spend a month, finished his fellowship, and just spent the last 2 years working in Rwanda as one of the junior faculty there. So you can see it's kind of a busy, crowded setting, shared airspace here because the wards are just separated by these sort of half walls. Little privacy offered to patients. And what was most striking for me about this work, compared to working back home at Dartmouth Hitchcock Medical Center, is, not surprisingly, but how many young people died every week. That is what made the work particularly challenging and difficult. I think of many of the patients that I took care of there. There was one in particular, a 26-year-old young man who probably hadn't gotten antibiotics when he had the strep throat as a young kid. The infection ended up affecting his heart valves, which ended up making his heart a less effective pump, which ended up making his heart very dilated and not a very effective pump in the end, and so dilated at one point that even valve replacement probably wouldn't have been effective. He really needed, at that point, probably a heart transplant. 26 years old, came in, we gave him oxygen, we tried to keep him comfortable, had the cardiologist see him. There was really nothing we could offer him at that point except for a death with dignity, and encouraged his mother to stay with him, hold his hand by his side during the night when he took his last breaths. And what's tragic about that death is that it's preventable. There's not an easy fix here. This is a complicated systemic issue, but there were many points along the way in the system where, had he gotten the right antibiotics as a kid, had he even gotten care for the infection that he had as a kid, and had he gotten the right treatment, had he been seen maybe when he first started having some cardiac issues and the valves first started failing, could there have been an opportunity for intervention at that point? Different points along the way in which there could have been an intervention and maybe his life could have been saved. That was the hardest part about this work. Made it very draining, but on the other hand, at least knowing that we could offer, in this case, some comfort, palliative care, and maybe a death with dignity. That was about what we had to offer. So as I mentioned, too, we believe very strongly in the concept of reciprocity. So if we are going to send, we are going to receive. So this is a picture of 2 recent Rwandan trainees, Dr. John Butanzi and Vincent Sigora, who spent 2 months, the better part of 2 months at Dartmouth Hitchcock Medical Center getting training in neurology and in gastroenterology, training that they probably couldn't have gotten at home because they don't have the specialists there, but training which they can apply to their setting when they go back home. We're looking forward on having 2 more Rwandan trainees come later this year, and we currently have active bilateral exchanges with our sites in Kosovo and in Tanzania, and looking to build more. So I have to stress, too, that it's actually more than just medicine, right? I've talked a lot about the hospital setting, medical care, but of course it's more than just medical care. And so I share with you here 2 pictures of our 2 recent students who traveled to Rwanda last summer. Marina, who is studying anthropology as an undergraduate, and David, who's a second-year medical student who had spent a gap year before coming to medical school, working in Uganda, setting up a business, his own business there. So very familiar with East Africa. And they both went to work with colleagues in the Ministry of Health and helped them work on vaccine policy. So what was their role? They helped with some of the data analysis. They helped with some of the writing up of some of the results and helping get some of the great work that they're doing at the ministry out the door as manuscripts that could be published and shared more broadly. That's a great role that they could play, and our Rwandan colleagues are very appreciative to have them there. what we really like too is that we at Dartmouth try to focus on sending, when possible, paired students, because it allows a little bit of peer mentoring to happen. And of course, we're always so pleased when the experiences don't just end when they leave the country. So in this case, Marina came back to Dartmouth and was so excited about her work there. Actually got very excited about pediatric care and children's medicines, and came back and worked with a group of Thayer students and Thayer professors to develop a widget, a gizmo, that kind of looks like a complicated pepper grinder in which you could put in different medicines, kind of grind it in the right way, and it would dispense at the right, dispense a powder with the right concentrations of all the different medicines for that child's weight. And then the parent could just take that single powder and mix that with food or liquid to administer to the child. Something she was very excited about, their colleagues were very excited about, and the Minister of Health was very excited about. So they're kind of taking this to the next step. I've connected them with some of the drug development folks in the international TB world, and we'll see where this takes them. But it's very, very exciting that she was so inspired by this experience that, again, it didn't just end when she got on the plane to leave Rwanda. David, likewise, he's a medical student, so has a little bit less flexibility in his program, but certainly when our Rwandan colleagues came to spend their 2 months at Dartmouth Hitchcock Medical Center, he helped in hosting them and felt very strongly about staying connected as he could. So another important part of our work is to work with local champions. Right? This program is a Rwandan-owned and run program. And there's no doubt that the owner of this program, the person leading this charge, is the Minister of Health in Rwanda, Dr. Agnes Binagwahu. Now, you see she was appointed as the Minister of Health in 2011, but she also has very strong Dartmouth ties. You see her getting an honorary degree at commencement in 2010, and she also was recently appointed as Professor of Pediatrics at the medical school. She is a phenomenal woman. She is charismatic, she's dynamic, she drives her team so hard. She says, we can't wait, we lost years during the genocide in Rwanda. We have to do this not tomorrow, not today, we had to do this yesterday. And she is a driving force in the country, and I think maybe single-handedly responsible for many of the amazing health statistics that I was sharing earlier. What a joy it is to work with such an impressive partner and leader, and how much we're learning from her, and how she's able to get things done. So partnership, again, key part of our work. I'm pleased to say that Dartmouth has made itself a good name and is a respected partner in the field, and for very simple reasons. We honor our commitments. We do what we say we're going to do. We try to underpromise and overdeliver. We don't try to monopolize the leadership of any project or program. And all of that has paid off in spades. So I kind of represent that with a picture of one of our surgeons who was in Rwanda for 6 months, Dr. Nick Perencevich, who is here operating shoulder to shoulder with his Rwandan counterpart, Dr. Charles. And this is a picture of me with my Rwandan counterpart, Dr. Jean-Luc Nkurikiimfora. I was so pleased and fortunate to be partnered with Dr. Jean-Luc when I arrived in Rwanda. Dr. Jean-Luc is the head of the HIV clinic at the main teaching hospital in Kigali, and clearly a rising star in the Rwandan healthcare system. As the director of the HIV clinic there, he sees more HIV patients than we see in months, years, all together at Dartmouth Hitchcock. There's nothing I can teach him about HIV care. He could teach us a lot, but there's nothing I can teach him. But the way I approached our partnership was to say, tell me what your professional goals are and how I might help you achieve them. And it turns out what he was most interested in was studying how his clinic operates and trying to set some metrics and interested in doing some quality improvement work. Well, that was very exciting because that's something that actually I could help him with. And if I didn't have the skills, I could connect him to people at Dartmouth who did have those skills. So I'm very pleased to say we've been able to continue to work together, even though it's been 3 years since I was in Rwanda. We've been able to continue to work together on some of this work, I think because of our shared vision and commitment to this work. And then lastly, I think about what our main impact is in this work, and it is really about building the human capital in Rwanda. And we do this through a variety of ways. And one of the ways that we do this is by sharing the kinds of teaching that we do here at Dartmouth with our partners in Rwanda. And let me give you an example of that. So the first week that I was in Rwanda, I attended one of those clinical case conferences where this time it was a resident presenting a complicated clinical case. And it was very interesting what happened. She started to present the case. The faculty started to kind of grill her in a way that many of us in medicine, especially those of us that trained several years ago, are very familiar with. Saw her getting grilled. I saw this really smart, talented young resident, sweat break out across her brow, her voice begin to quiver, her hands start to shake a little bit. Yeah, she was just feeling awful. And I remember thinking to myself and talking it over with one of my other US colleagues about, gosh, what can we do about this? We really want to show that there could be a better learning in a supportive, nurturing environment. How do we do this? So again, fast forwarding 6 months later, we saw this case conference transformed. And how did that happen? It wasn't because we actually pulled aside our Rwandan colleagues and said, let us tell you about what we know about adult learning theory now and about adult education and how we do conferences back home and how to make the residents feel supported. We just modeled a different behavior. We just started to say, that was a really great presentation. Here's what you did really well. Did you think about this in your differential diagnosis? Or did you think about this when you were working up the patient? Or had you considered that? Or explain to me why you chose to do that test and not this test. And just modeled this different behavior. And what was fascinating was it really caught on. I think everyone began to see that this was now a much more productive educational environment for the residents. And again, didn't have to do it by telling. We could do it by showing. And obviously, sometimes actions speak louder than words. So what I'd like to do now is move east and take you to visit our programs in Dar es Salaam, Tanzania. This is actually one of our oldest partnerships. And I'll tell you more about all the programs that are involved. But just to begin with showing you this picture, sort of a quiet moment in the Dar es Salaam, which is a port city. And Dar es Salaam actually means harbor of peace. And let me begin by talking a little bit about the impact of the HIV epidemic in Tanzania. Now, Tanzania, particularly hard hit. At the peak, about 10% of its adults were infected with HIV. And we know what happened. Essentially, a lost generation to HIV. A generation wiped out. And so what you see remaining are scenes like this. So this grandmother, we'll call her Fatuma, inherited her 6 grandchildren to take care of, right? Because her kids had passed away. In addition to that, she inherited the neighbor's 3 grandchildren. So now she is taking care of 9 grandchildren, some not her biological grandchildren, but now all of them essentially her children. And while we think about the HIV epidemic and TB on top of that and think about all the deaths that the epidemic caused, this is what the HIV epidemic looks like for those that were left behind. So because of how hard hit this country was by HIV, and with TB being the leading cause of death amongst those infected with HIV, it's probably not a surprise that we chose to focus our programs on TB and HIV and the co-epidemics. And let me just tell you about a couple of our programs. First of all, we call them the Dar Dar Programs. And how did that name come about? Well, we were talking with our Tanzanian colleagues about what could be a name for our collaboration. And obviously, Dar Dar is taking the first syllable from Dar es Salaam and Dartmouth to come up with Dar Dar. But our Tanzanian colleagues said, oh, we really like that. And why did they like it? Because they said it mimics the Kiswahili word dada, which means sister. And we all agree that that kind of captures the spirit of our relationship. So we are now the Dar Dar Programs in Tanzania. And we have clinical care, education, and research training programs. We began as a research enterprise, and I'll tell you more about that on the next slide. But let me tell you a little bit about our clinical care programs. The Dar Dar Pediatric Program is that pediatric HIV care and treatment center, which I introduced to you already, established in 2006. And let me tell you how this program came to be about. So the head of our programs, Dr. Ford von Rijn, who's also a Dartmouth College alum, class of 60-something, he was in Dar es Salaam on a site visit for one of the research programs and working with our study coordinator, Dr. Lillian Mte. And they were seeing patients together throughout the week, and there was one woman who kept coming back. She came back 3 times in the same week with these sort of vague, nonspecific complaints, couldn't figure out what exactly was going on with her. And finally, on the 3rd visit, she broke down crying and told Lillian in Swahili that her 3-year-old daughter had just been diagnosed as HIV infected. And at that time, this is before 2006, there were no treatment programs, no treatment options for kids. And so Ford and Lillian looked at each other and said, we have to do something about that. And they were able to successfully get some seed foundation funding to establish the Dar Dar Pediatric Program, the first site to offer HIV care and treatment for children in Tanzania. Since then, I'm pleased to say there have been others that have followed suit. We now have about 700-800 children enrolled in care and treatment and a few hundred adults. So we provide family-centered care, focusing on the kids, but of course provide care to any adults that come along with them. In terms of education and training programs, we've been fortunate to get some funding over the last decade from the Fogarty International Center of NIH to do training around TB and HIV care and research. And I share this fact because NIH likes to measure success by how many publications you have. So this number means a lot to them, but this is the metric that I think is more important. So out of the 25 publications to come out of our collaboration and training programs, 21 of them have Tanzanian first authors, are led by Tanzanian colleagues. That to me is a much more meaningful metric. And then, of course, I mentioned our bilateral student experiences that we've had for a number of years, and then our research, which has been focused on TB prevention and consequences of having TB and HIV. This is just a crummy cell phone picture that I took of our last training program. Sorry, it's not very clear, but it was a joint training program held together with the Ministry of Health and Dartmouth collaborators in Dar es Salaam this past January. And then, of course, we try to engage our students in the education and clinical research that we're involved in. This is one of our medical students working with. That's Dr. Lillian Mte that I was talking to you about. Here she is teaching him how to read a TB skin test. And then our students are also so enterprising and driven that they actually take their own initiative in many instances. So this was Faith, who was a Dartmouth College undergrad and then stayed here for medical school as well. When she was working at the pediatric HIV clinic, she realized that some of the students were struggling in school and thought that she could actually help by volunteering at the school and doing some tutoring. So that's what she did. And then lastly, I'll just finish up talking about our TB research and our focus on trying to identify a new TB vaccine. So as I said, this collaboration began as a research enterprise. In 2001, we got NIH funding to start a large phase 3 clinical trial of a new experimental TB vaccine candidate. We enrolled over the next several years 2,000 patients in that study. And it was in 2009 when the principal investigator, Dr. Ford von Rijn, got that phone call that researchers wait their entire careers to get. It was a call from the Data Safety and Monitoring Board, the only body involved in the research that knew who was getting placebo and who was getting actual vaccine. And they called Dr. von Rijn to say, you can stop the study, the vaccine's effective. So we were very pleased at that point. It was shown to provide 40% protection, not as high as we would like in vaccines, but the best option for protecting people, keeping people from dying from TB who are HIV infected. Very exciting. It is the only vaccine candidate to date for TB that has been shown to be effective in humans. So immediately what had to happen was discussions with the manufacturer to say, okay, we want to be able to produce this on mass, for scale up, for mass production. How do we do that? Make it available to countries at low or no cost. And what we realized is they needed to be able to have a different method of producing the vaccine for scale up. And so once they had accomplished that, we have to do these sort of mini trials to make sure that the same vaccine, but just with this new production method, retains its safety and efficacy. So we're doing the studies now in Hanover to make sure that it retains its safety and immunogenicity, and expect next year to be doing the larger mini phase 3 clinical trial to make sure that it retains efficacy, and doing that in Tanzania next year. But still a very exciting moment, and it's been such a privilege for me to be on the team and have Dr. von Rijn be a mentor. So I'll just leave you with some thoughts about our going forward. What do we hope to do in the future? Of course, we want to continue to grow and deepen our partnerships and programs while we maintain what I consider to be that Dartmouth quality, that integrity in our partnerships, that focus on health equity to our programs, on equitable partnerships in our programs, on reciprocal relationships. We're always trying to raise resources to support our activities, of course. But ideally, we would like to see Dartmouth become a leading institution for health equity, that this becomes known for its work in health equity. And ultimately, for our graduates to have an impact in the world. I think you all probably can imagine the kinds of impact that these programs have on our students' lives and in changing their career trajectories. And I'll just share one quick quote from one of our medical students, Nareth Carlisle, who graduated a few years ago, when he said, "When I arrived in Dar es Salaam, Tanzania, I thought I knew what to expect. But the experience was so much deeper than I had imagined. That experience galvanized my commitment to global health." And interestingly, Nareth is someone who grew up in South Africa, so he was not a stranger to Africa, and yet this still altered his views and altered his career trajectory for him to pursue global health as a career, which he went on to do, training in global health and internal medicine at Brigham and Women's Hospital. So I like to end too. I'm always happy to talk to alums who might like to learn more about our work and find ways for getting engaged. So I'm happy to do that if any of you are interested. But we really see that this is just a great moment for really bringing health equity home to Dartmouth and to really strengthening and growing what we've started with our international partnerships overseas. And this kind of sums up our approach to all of this. If you want to go fast, go alone. If you want to go far, go together. So I'll end there. Thank you.
Okay, so we have time for just a couple questions. And Danielle and I have microphones, and we're doing that so we can catch it on the recording. So please just raise your hand, and one of us will get a microphone to you. Danielle's good.
Hi, I'm Joyce Saki, class of 85.
Hi, Joyce.
Lisa.
How are you?
Good, how are you?
Good to see you.
Good to see you. Thank you for a terrific presentation, really inspiring what our college is doing, what our medical school has been involved in. I want to ask a question about the point you made about reciprocity. And I wonder how you're balancing the ideal of reciprocity in an era where we know that funding, including NIH funding, is shrinking. For instance, the example you gave of your colleague who wanted to do sort of quality improvement research,
Right.
how do you ensure that he actually has the resources to do things locally in a way that is meaningful for both institutions?
Yeah. No, it's a great question, and it also just gives me the opportunity to point out that if you are going to, walk the talk and say you support reciprocity, I didn't highlight this, but I think it's worth knowing that for our partners coming here, we cover all those expenses. So we fund our students to go over there, but we also fund our partners' institution students to come here, because how else is it going to happen? There's ways in which they can support and provide, assistance here and there, but we're funding the majority of it, and I think that's what needs to happen. That's how this is going to happen. And again, that's an example of our commitment to this work and to having the bilateral exchanges. And we know that they're so critical. They make our environment here so much richer and deeper, and help our students and faculty learn so much by having them in the classroom on the wards. So, I do think that we are gaining as well by supporting them to come here. Boy, the funding scene is not such a pleasant one right now, as you point out. NIH funding, opportunity shrinking, the odds of getting funded for a first-time applicant just harder and harder these days. I will say, and you probably are aware of this too, from the great work that you do in Ghana, there are some opportunities that are for applicants from low-income countries. So we share those with our partners as much as we can, but it's more just about forwarding the link. It's really about working with them to have a successful application and to have a successful implementation of a program. So for our students who come here through one of our Fogarty training grants, they come here either to do a master's in public health or to get a PhD. Well, it's the PhD graduates, in some ways, that we are most concerned about, because when they go back to Tanzania, in this case, we really want to make sure that they have the resources and environment in place to be able to be successful. So working with them on getting their first R01 grants submitted, working with them on making sure that their home institution is prepared to provide them the lab space that they need and the support staff or whatever it might take. I will say 100% of the Tanzanian health professionals who have come to Dartmouth to get an MPH or a PhD, 100% have returned to Tanzania. That's actually not what I think is the hardest part. The hardest part is getting them to stay in Tanzania, making sure that they have the resources and the setup so that they can be successful, because what often happens is people go back for a couple of years and they hit brick wall after brick wall with not getting funding and becoming externally funded, and then that's when they look to emigrate. So you probably know all this. Joyce can tell you a lot about the programs, fabulous programs that she's led in partnership in Ghana. But those are the things, those are the areas where we're really focusing on, trying to make sure that people are going to be able to be successful, and working with them in applying for these unfortunately limited opportunities. Yes.
Peter Boone, class of 80. Congratulate you on your work. Definitely a motivating individual for our medical students. I have a specific medical question. Is your vaccine effective against atypical mycobacteria as well as typical?
Yeah, about the MTB complex.
Yeah.
So I don't think we have data on that. There's not good diagnostics for identifying the atypical non-tuberculous mycobacteria. They're probably those infections are probably very common in low-income settings, places such as Tanzania. But that's not something that we have data on that I'm aware of. It would be something that would be nice to know, but with TB and the bacteria and the MTB complex being the most commonly identified leading cause of death in HIV-infected individuals, we're at least pleased that it provides protection against those.
Hi. In your biography, it was mentioned that you do TB control as well in Africa. Could you talk a little bit about what that entails and the positive and negative effects you've seen of the exposure to TB in different African communities?
Sure. So the last part of the question is
the positive and negative effects that you've seen
around
and impacts of having access to TB in those countries.
Okay, sure. So if I understand your question correctly, the work that I've done in TB control overseas has mostly been around technical assistance, so supporting programs, either with, it could be anything from developing more comprehensive infection control practices to developing clinical guidelines for pediatric TB. A small group of us worked most recently with the Ministry of Health and a large NGO called PATH in Tanzania to help develop comprehensive pediatric TB clinical guidelines, and involved in the training and the rollout, and went back and to do some of the monitoring and evaluation about how closely the guidelines are being adhered to. All positive reports from that work, which is great. I've also helped ministries of health apply for funding for TB control. So I've been involved in 2 different large applications to the Global Fund to fight AIDS, TB, and malaria, that were, I'm happy to say, successful and brought in tens of millions of dollars to those countries, to their ministries of health to work on combating TB and HIV. So it's still challenging work. There's still a lot to be done. We know in globally, TB, there's about 9 million cases every year, and about 3 million of them are what are called missing cases. So cases that have gone undetected, unreported, but our best epidemiological estimates tell us are there. So still much work to be done in terms of identifying all the cases that are out there and getting those into care. So that's some of the remaining challenges to this work.
Just one more.
Okay.
Hi, I'm Gail Frawley, a class of 79. Thank you for a very interesting presentation. When I first learned a little bit about this program when it was getting started, it was through Doug Merrill, because he and I sit on some SAMBA committees together. He mentioned that the program was essentially a seven-year program. The idea was to build capacity and then turn it over to the host country. Mm-hmm. But my question is, have you had any challenges with turning it over to the host country, and how do you know that 7 years is the right amount of time? And I would imagine, let's say in a country like Haiti that has very little infrastructure, it'd be so difficult to come in, build all this capacity, and then turn it over and see it maybe perhaps not continue.
Yeah. So the 7-year turnover or 7-year program length refers to specifically to the Rwandan Human Resources for Health program. And how did they get 7? Why not 6? Why not 8? A little bit hard to know exactly. We sort of knew it had to be more than 3 or 5, and again, I think the duration was determined by the Rwandan leadership. The idea also being that that would be the time period that they would need to be able to reallocate resources to be able to absorb the newly trained physicians in their system. So it wasn't just about strengthening their training programs, it was also about increasing numbers. So for instance, in internal medicine, the number of residents that were trained doubled the year that we first arrived. So at the hospital I was at, they had previously had 12, it went to 24. So you need to be able to, that's great, you're going to be able to train, you have to pay them while they're residents, because residents do get, not large, but some salaries. And to be able to, though, hire them, have jobs for them when they finish training. That, I think, is the challenge, and something that the Honorable Minister, Dr. Agnes Beniguahu, the head of the Clinton Health Access Initiative, has heard me say many times, are we sure that there's going to be opportunities to hire these physicians when they graduate, when they finish training? Because otherwise they will leave, right? They've just had this sort of, buffed up training program and opportunities. They want to stay, but they need opportunities for job prospects. And I've been assured repeatedly that they are accounting for that and making the appropriate planning. We've had problems. There have been challenges in the program. We're actually now we're finishing year 3 out of the 7-year program and doing sort of a mid-course review. The Clinton Foundation is putting people back on the ground to help with some of the administration of the program, because it's been a challenge for the Ministry of Health to handle working with however many schools now. We're up to 15 schools maybe in total, and managing all the budgets and separate nuances of each of the different schools and their financial reporting systems, et cetera. So they're putting in some support. So it may be more than 7 years. But I think the idea is that there is a time period in which things will be transitioned over. And that's, I think, the ultimate goal, whether it's 7, whether it's 8, whether it's 10. It almost doesn't matter if this is overall successful.
Okay, well, great. I'd like to take another opportunity to thank Lisa for that inspiring presentation.
Thank you all for staying.